We all know that the burden of ST myocardial infarction is increasing dramatically globally as well as in countries like India, and the management of such patients and achieving the early reperfusion is becoming very challenging. And the dilemma remains whether to go for the primary PCI or whether to go for the thrombolysis as far as the achieving the early reperfusion is concerned. So to discuss this in more detail, I am honored to have with me the legend interventional cardiologist from Australia, Dr. Richard Lim. So welcome to the show, sir.
Thank you very much.
Sir, coming to the topic, as far as the management of ST myocardial infarction is concerned, how important is achieving the early reperfusion and what advice you would like to give for achieving the same?
Well, we must always remember that when we're dealing with ST elevation myocardial infarction, time is really muscle. Right. Every minute counts. Every time delay of a minute translates to a 7.5% greater risk of mortality. And so we have to get our systems on the go, ready to launch at any time of day or night. So it is crucially important that we devise our systems to allow us to offer that treatment, that reperfusion therapy in a very timely fashion to the patients so that they can derive the greatest benefit.
Okay. And what treatment modality you would like to recommend, whether to go for the primary PCI or whether to go for the early thrombolysis?
That's always the question to ask, and you need to look at the system where you're practicing. I think if you have a setup where you have ready access to a PCI lab, and there's a hospital that's capable of offering a slick service, then that is always going to be the treatment of choice. For example, in Brisbane, Australia, where I work, if you live in perhaps a more rural setting, even in Queensland, and it is anticipated that the time from your myocardial infarction being diagnosed to you getting that blocked artery open is going to be more than 90 minutes. Then you really should be revamping your system to allow that patient to receive thrombolytic therapy as quickly as possible, and preferably within 30 minutes of presentation to either the hospital or the ambulance service.
Right, sir. So, sir, as we know that and various guidelines recommended that the primary PCI is the gold standard, provided the patient is reaching the cath lab within 120 minutes of first medical contact. But in countries like India, there are various challenges in reaching to the cath lab center, and secondly, the number of cath lab facilities that are available are also limited. So, in such cases, whether early thrombolysis with thrombolytic agent is the preferred choice?
It definitely is. Even in a country like Australia, which is a very spread out, we have the same issues in terms of not enough hospitals, not enough labs performing PCI, and the great distances that the patient has to travel to get to medical attention. And so if it's expected that the time for that journey is going to, if the time is expected to take more than 90 minutes, then the patient should be receiving thrombolysis within 30 minutes to derive the greatest benefit.
Right, sir. And as far as the thrombolysis is concerned, which particular thrombolytic agent you would like to recommend as the treatment of choice for managing such patients?
Well, the latest one with the best evidence is tenecteplase, and I understand that it's widely available in India as well. It can be given as a bolus, and so in fact it becomes very suitable for use out in the field, meaning in the pre-hospital setting, because a medical team or paramedical team can get to the patient, cut out the transport time, get to the patient as expeditiously as possible, administer that as a bolus, and hopefully allow the reperfusion process to start working, because time is muscle.
Right. So, sir, as we know that the tenecteplase can be given just a single injection within 5 seconds. So, will that play a significant role as far as achieving the early reperfusion is concerned?
Absolutely, because we know that the quicker it's given, the more chance it has of lysing the clot that's causing occlusion of the coronary artery, causing the STEMI. And so, yes, the quicker it's given, the better.
Right, sir.
And in our practice in Brisbane, we have a drip and ship system where the patient receives it at the field or in the peripheral hospital, and then they're very quickly transported to a PCI hospital.
Okay, okay. And sir, what is the significance and the future of the pharmacoinvasive approach for the STEMI management?
I think that is, if you like, a product of the way that we've allowed the system to evolve, and it also is very, very closely aligned to the STREAM protocol, which was one of the most recent thrombolytic trials, and that is that even if you have responded successfully to lysis, you would, within the next 24 hours, be undergoing coronary angiography to see if there is a culprit lesion that still needs to be tackled by PCI.
Right, sir. So, sir, as far as the 1080 place is concerned, apart from the rapid administration just in 5 seconds, what are those other factors which are favoring 1080 place and is being preferred by most of the cardiologists globally?
I think the ease of administration is certainly the big winner here. And that has come at a time when it was increasingly recognized that we get the best results if that lysis is given by trained personnel out in the field where the patient is, where the patient is suffering his acute heart attack.
Okay, so thank you so much, sir, for throwing a light on the STEMI management with primary PCI as well as with the thrombolytic agents. So thank you so much for your time, sir.
My pleasure.